Good afternoon and welcome to the Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies Spring Webinar Series focusing on the behavioral health workforce. We are pleased to have you all joining us for today's webinar. My name is Christy Friedman and I am the Program Manager for the Center. This spring series will run as a four-part webinar series from February to May of this year. Please save the date for our next webinar, The Challenges and Opportunities Facing the Psychiatric Mental Health Nursing Workforce, to be held on May 11th at 1 p.m. Eastern Standard Time, featuring Dr. Kathleen Delaney, a professor at Rush College of Nursing. We have a wonderful blog post detailing the genesis of this series of webinars and future dates to hold on your calendars if you visit our website at healthworkforcestudies.com. A couple of center announcements to mention before we begin today's webinar. We've posted new Current Trends of Men in Nursing report that updates data we previously had released in 2014 on our website that has new data on the number of men working, minorities by gender, age by gender, hospital settings, and new degrees awarded to men. And this new data brief is now available on our website at the same web address, healthworkforcestudies.com. Secondly, summer is right around the corner. Save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers Conference titled The Nursing Workforce and Health Reform, Trends and Opportunities in a New Political Era. This conference is being co-organized by our center and will be held June 7th through 9th at the Grand Hyatt Denver in Denver, Colorado. More details, including sponsorship and registration information, are available on the National Forum of State Nursing Workforce Centers website at nursingworkforcecenters.org. So you can visit our website for all of this information as well, again at healthworkforcestudies.com. After today's presentation concludes, we'll have 15 to 20 minutes for discussion and question and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many as we can. We're also recording the webinar today, and we'll have it posted to our website. We have posted all of our previous webinars to our website if you have missed any of our previous ones. You can also find presentation slides for many of the webinars posted within the Video Library tab on the website as well. Now, I would like to turn the microphone over to Peter Bierhaus, Center Director, to take a moment and introduce our speaker. Peter?
Hey, Christy. Thanks very much, and welcome everyone to today's webinar. I'm coming to you from Bozeman, Montana, where spring has arrived finally. The grass is greening up, but tonight we'll have 3 inches of snow. The other big news is that the bears are all emerged from hibernation, and that means we have got to get our bear spray out again when we're hiking. And finally, my research assistant and her boyfriend were riding their bicycles in Yellowstone National Park last weekend and were met by a small pack of 6 wolves who split up into 3 wolves on each side of the road and escorted them out of the park, said, "We're not ready yet for you humans, so come back in a month." So life is exciting here. And speaking of exciting, it is my great pleasure to introduce our webinar presenter today, Dr. Ron Vanderscheid. Ron serves as the Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. And I'm going to just read through a few of the things that are about his bibliography, but I've excluded quite a bit, but still you'll see the great depth and breadth of knowledge that Ron possesses. So Ron is also the Executive Director of the National Association for Rural Mental Health and Adjunct Professor at the Department of Mental Health in the Bloomberg School of Public Health at Johns Hopkins University. Now, Dr. Vanderscheid serves on the boards of the Employee Assistance Research Foundation, the Danya Institute, the Frameworks Institute, the Council on Quality and Leadership, and the NASHBID Research Institute. He also serves as the co-chair of the Coalition for Whole Health. Dr. Vanderscheid is a former member of the Secretary of Health and Human Services Advisory Committee on Healthy People 2020. He's the past president of the Federal Executive Institute Alumni Association Foundation, past president of the FEIAA, not sure what that is, Ron, past chair of the American Public Health Association, Mental Health Section, and a past member of the APHA Governing Council. He has served previously as the chairman of the Sociological Practice Section of the American Sociological Association, president of the Washington Academy of Sciences and the District of Columbia Sociological Society, and it goes on. But one last thing, Ron has served as principal editor for 8 editions of Mental Health, United States. He has also authored numerous scientific and professional publications on services to persons with mental illness and substance use conditions. It is really a great pleasure to turn the microphone over to you, Ron, and we are all in for a great treat today. So Ron, you hold the microphone.
Okay, thank you very much, Peter. You're far too kind to me. I'm going to do a number of things today. I'm going to talk a little bit about developments in behavioral health and some of the implications of those developments for how we go forward, and then also a little bit about some pending legislation and what we might expect there. I'm not going to really talk much about human resources, but I did want to begin with a little bit of a thrilling ride for you on human resources in behavioral health. So the thrilling ride here is that behavioral health workforce is in crisis currently. And this crisis has been coming for a very, very long time. What's happening to us, the baby boomers are now reaching retirement age, and most of our senior positions in the field, the state director positions, the county director positions, the directors of community mental health centers and substance abuse centers and so on, mainly have been baby boomers, and they are now beginning to move out. The next generation down, we call the baby bust generation, are people who never came to behavioral health. They're the people who would have begun their careers in the Ronald Reagan administration, and people did not go into health or behavioral health in those days. They went into law, they went into business, and so on. So we don't have a ready set of people to move into the baby boomer positions. The Affordable Care Act has vastly expanded demand, so we've added now approximately, I'm going to say about 21 million people, and above those 21 million people who now have insurance, either through the Medicaid expansion or the state insurance marketplace, probably at least 25% are people who have primary behavioral health conditions. The opioid crisis, which you're all aware of, has grown and continues to grow. We're now losing about 142 people a day as a result of the opioid problem. And we're simply not training clinicians in sufficient numbers. The universities are still acting as if it were 1990, not 2017. So the numbers that are being trained haven't really increased. And in a certain sense, we're training people with yesterday's knowledge in behavioral statistics. So if I were to produce a research paper today and it were published in a journal today, it would be 17 years before that knowledge appeared out in the practice of behavioral health, with a few rare exceptions. So the cycle here from research to knowledge to practice is just far, far too long. So obviously in this area, and then I'll stop talking about this and go on to other things, we need a new strategy going forward here. And I want to call out the University of Michigan Center on Behavioral Health Workforce Research is actually a breath of fresh air after a gap of about 10 years in this arena, where this area is finally beginning to get some attention again and needs to have the attention for all the reasons that I just indicated here. So what I'm going to do is talk first about some very recent developments, then look at how some of these things impact upon behavioral health care, and then talk a little bit about legislation. So first thing here, last summer President Obama had a task force on parity for mental health and substance abuse. I've shown the URL here for how you can link to that report. The critical thing about that report is that it was attempting to move the agenda on parity. So the original parity legislation was from 2008, and then it was enhanced in the Affordable Care Act in 2010. Even as late as 2015, we're only getting to the final regulations regarding this. So there has been relatively little complete uptake in the field. And the purpose of the task force and the report was to jumpstart that area. And it makes a number of very important recommendations that there's more training and technical assistance needed, for example, to state health insurance commissioners, many of whom I'm sure don't really understand this area very well. There's training and technical assistance needed to insurance companies. What do I need to do to comply as I develop these insurance plans for the marketplace and so on. And even training and technical assistance to consumers. How do I know when my parity rights are being violated or not violated by insurance? The report actually focuses upon consumer reporting of violations, and we do think in the Coalition for Whole Health that's very important, but we don't think the whole burden should fall on consumers. We think a lot more of the burden belongs on the state health insurance commissioners and the insurance companies on the front end of the process. So we are continuing to work with HHS on that issue to try to move the agenda upstream. Some of the actors in this area that are important if you want to look at what's going on, probably the biggest actor in this area is the Kennedy Forum run by Patrick Kennedy. And if you go to the kennedyforum.org website, you'll see a lot of materials, including some tools that can be used to actually figure out how to report a violation and so on. Another thing that this report did was recommend some penalties, and there were financial penalties. Obviously, nothing can happen on that unless there's legislation, and right now there's no legislation pending. But parity is a very, very important issue because parity is what gets behavioral health to the table. Had we not had the 2008 parity legislation, we would not have been at the table as well in 2010 for the Affordable Care Act. Another very recent development is the 21st Century Cures Act. Two major pieces in here that are very important: the Mental Health Reform Act of 2016. And the 21st Century Cures Act, I should say, is an authorization bill, not an appropriation bill. So it authorizes the appropriation of money but doesn't actually appropriate it. So the Mental Health Reform Act, I'm saying about increased grant funding for services integration, and some funding for human resources, which I know many of you are interested in, particularly in the National Health Service Corps. Again, those are authorizations, not appropriations. They need lobbying to translate the authorization into an appropriation. The Mental Health and Corrections Collaboration Act was also included in the 21st Century Cures Act. That's very important to behavioral health because it's the very first time that Department of Justice grant funds can be used when people re-enter the community from jail for services for those persons, whether they be mental health or substance use services or health services or social service. So that's a real breakthrough. And again, the money is authorized but not appropriated and needs advocacy. The one area where that particular bill actually did appropriations was in the Comprehensive Addiction Recovery Act, where we were authorized $1 billion, $500 million in 2017, and another $500 million in 2018 to address the opioid crisis. And currently, SAMHSA is awarding the first $500 million. If you are in a state where this is a significant problem, or you're in a county where this is a significant problem, make sure you find out what is happening to the money that is going to your state. And the money will go through the single state agency and then will be appropriated down to the counties and providers based upon the severity of the opioid crisis in your county, as determined by how many deaths have occurred and what the prevalence estimates are for opioid disorders in that county. So, but this is a very important breakthrough in this bill again, because when we started advocacy for this bill, we were at $200 million, and we were able over 6 or 7 months to get that $200 million up to $1 billion. And $1 billion sounds like a lot of money, but compared to the opioid crisis, it's really just a big down payment on the opioid crisis. Okay, some other developments. Also in 2016, the Center for Medicaid and Medicare Services issued a new managed care regulation. And what's very interesting about the managed care regulation is that for Medicaid managed care programs, those Medicaid managed care programs can now use federal financial participation for what were known as traditional IMD, Institution for Mental Disease Services, both for inpatient and for residential treatment, and I know those are used differentially in mental health and substance abuse. So this is the first time in more than 50 years that we've had this kind of breakthrough on being able to use IMD funds, and the law and the regulation as it existed previously was just very, very much out of date. Also in the spring of 2016, the CMS issued a letter to the state Medicaid directors indicating how Medicaid, federal Medicaid funds, federal financial participation could be used for people in criminal justice settings. The law basically says that if someone is actually in a cell, Medicaid funds cannot be used. What this letter clarifies is that in any other setting a person is in, home detention, probation, parole, transferred to a hospital, Medicaid is totally appropriate and can be used. And that's a real help because the entire burden of the health care for people in the county jails has fallen on the counties because we haven't been able to use any Medicaid funds for care of that population. Another new development here, there are new what are called 1115 Medicaid waivers. The one I'm calling out here is one in California that is for the purpose of putting in place systems of care for substance use clients in all 58 counties in California. And what's very interesting here is this is the first instance where an 1115 waiver has been used to permit the use again of IMD funds for community residential care, and you see it can be up to 90-day maximum for adults and 30-day maximum for adolescents. Again, a huge change from what has been true in the past where federal funds could not be used for that purpose. And a little note I also put on here, since the Trump administration has come to office, governors are coming to discover the importance and power of 1115 waivers in doing adjustments to their state Medicaid system. So if you're not knowledgeable about the 1115 waivers your state has or the waivers your state is applying for, I encourage you to look into that. So going on to some more things here, I'm showing here the thing has become much more complex and it will obviously continue to do so. What are some of the key game changers in behavioral health? One of the key game changers that's up to bat right now is what's going to happen to the Affordable Care Act. And I'll come back and talk about that a little bit later. There's also some exciting new things. Early intervention with first episode psychosis. Every single state now receives a set aside out of its state block grant funds for early intervention with first episode psychosis, which shows a lot of promise, not in preventing disease, but in preventing disease such as schizophrenia from becoming more severe. There's also very early work in what's called prodromal, the prodromal phase of illness, even before a person has symptoms. And that also is showing promise, but that promise hasn't been translated into any programs that actually reach out into the states or down to the counties and local providers. On practice, we've come to realize in the last 20 years that probably 75% of all behavioral health issues are caused by trauma. They aren't caused genetically, they're caused by trauma that people experience. And we've known for 50 years that people who are in the poorest social class have 8 times the rate of mental illness of people in the highest social class. And part of the causality of that clearly is the trauma that these people are being exposed to. So this realization has led us to do a lot of transformation in behavioral health focusing on trauma-informed care. Some of the underlying trends that are important here, for all the years I was in behavioral health up till about, I'm going to say, 2005 to 2010, everything we talked about was what I call deficit-based thinking. We look at people in terms of diagnoses, what their symptoms are, what their failures in functioning are, and so on. We did not look at people in a strength-based way. That is now beginning to change in health more generally. Person-centered care, whole person care, all of these things move toward a strength-based approach where we will look at people not in terms of their deficits, but in terms of the strengths they bring to a situation and how to improve those strengths. And what I'm making reference to here is a recent National Academy of Medicine panel where they were asked the question, you know, how should we measure adults with serious mental illness in the future? I went and gave testimony, and I argued you need to build some strength-based thinking into that. And if you're interested in that area, there's a whole special issue of one of the journals done by CDC that focuses on strength-based approaches for behavioral health. From separate to integrated services, probably the biggest practice problem confronting behavioral health right now is how it's going to move from being a separate system of care to an integrated system of care with primary care. And I'll come back and say a few more words about that in a few minutes as well. And then from clinical only to clinical and community together, what I do a lot of work with students, and students are now beginning to come to me and say, well, you know, I want to get a master's degree in social work, but I also want to have a master's degree in public health. Where can I go to get a single degree that does this? And there are relatively few places. There are some, but there are relatively few places that do this. That is going to become much more common because behavioral health is going to need to become actually in its practice also a public health discipline. So there are huge opportunities here in training and future careers to do that kind of work. Some of the key responses, there are some major things here, and I just mentioned them, and if you're interested, you can dig into them further. So the American Public Health Association has a major multi-year initiative on altering the negative social determinants of health. And social determinants of health are those factors in a person's life that determine their life chances. Poverty is a negative social determinant of health. Lack of education is another one. Discrimination is another one. A nurturing family is a positive one. So those social determinants of health influence your life chances, which then influence your health status and your access to health care and so on. So APHA has said, you know, we're going to take on the social determinants, and we want a healthy society where we have addressed the social determinants. So they have a 5-year initiative to actually work on this. Some of you may be interested in that if you're interested particularly in upstream things on prevention and positive health promotion and so on. Downstream, the UN has set personal and community well-being as a worldwide 15-year objective for 2030, including for the United States. We pay tremendous attention to our economic indicators. We pay next to no attention to the well-being of our population indicators. Comparing the U.S. with the countries like Sweden and Denmark, on a scale of 100, we're at about 55 or 56. Sweden and Denmark are at 75 to 78. Uganda is probably at 31 or 32. So why are we only at 57 or 58 if Sweden and Denmark are at 77 or 78 is really the issue. And it's basically because we don't pay attention to the well-being of our population. Rebuilding the stream here, major U.S. corporation beginning to embrace the culture of well-being, have come to realize that if we're going to be effective and we're going to be competitive, we need to have a healthy workforce and healthy families in our workforce. And the only way we can do that is by embracing a culture of well-being that recognizes not only that a person may have illnesses and so on, but that there's a well-being surrounding that person in every aspect of their life. Their physical well-being, their emotional well-being, their social well-being, their spiritual well-being, and so on. And a number of big companies, examples would be AstraZeneca, American Airlines, Ford, and others have taken this on and are developing this. So there are some very important developments going on out in the bigger environment that have implications for behavioral health care going forward here. So going ahead to some thrills in behavioral health. So taking out of what I just told you and then bringing it into behavioral health. So what are the implications? So the old model we had was disease is a personal characteristic, the role of the providers to treat disease, the goal is to restore functioning, and in that the focus is on clinical intervention, care system management, and care policy. Every one of you has lived in that world. If we go to the new model here, we would say disease is principally a community characteristic, and the best example I can give you of that is if you tell me the zip code you live in, I'm going to tell you a lot about your health. I'm going to tell you probably how long you're going to live, how good your lifestyle is going to be while you're living those years, what diseases you're likely to have, and so on. i.e., disease has become a community characteristic. If that be true, then the role is to change those communities, those zip codes where this is very problematical, and the goal is to improve community functioning there. So why do certain zip codes have these problems and others not? So in that, the focus becomes on community level interventions and community management and community policy, not just disease interventions and disease management and disease policy. So the task here, I think, for behavioral health is how we're going to blend this old traditional model, the disease-focused model, with the community-focused model going forward. And one way to think of that is in terms of the triple aim that came about as a result of the Affordable Care Act, which says, and if we're looking at the vision, the elevator speech of healthcare is we want better population health, we want better quality healthcare, and we want to reduce care costs. The triple aim. So triple aim is a very good way of bringing that together. One of the things I want to mention here, population health management is emerging as a very important tool in behavioral health care, and that tool is going to be used in integrated care systems, as I mentioned before, that bring together mental health, substance use, and primary care, and also incorporate disease prevention and health promotion strategies. Now, a very simple way to, well, before I do that, I'll show you this here. It says you've got a very rare condition called good health. Frankly, we're not quite sure how to treat it. And that is, I think, endemic of the whole healthcare system. The whole healthcare system has been a disease system and disease-oriented. It has not been oriented to health. So population health management is a tool to begin to make that change. So you can begin thinking about that with the realization that disease and health are not two ends of the same continuum. They are two continua, which I'm showing you here, and I'm showing them as if they are orthogonal continua. As soon as I move it from being a single dimension to two dimensions, then I have the possibility of different population groups, and I've shown that here as POP 1, 2, 3, and 4. Behavioral health has been, for the last 50 years, focused on population 4. We've done virtually nothing for populations 1, 2, and 3. Part of the future agenda is how are we going to broaden our approach from being an approach that deals with people mainly who have severe disease, who have very unhealthy lifestyles, and so on, to also encompass these other groups. How are we going to deal with population 1, a person who's very healthy, they have no disease, and they want to remain that way? What disease prevention tools do we have available? What positive health promotion and positive mental health promotion tools do we have available? And traditionally, the way you would do population health, I've shown it as 4 groups. You could envision each of these 4 as 2, so population 1A, 1B, 2A, 2B, 3A, 3B, and 4A, 4B, subgroups within each of these. A traditional population health model run by an insurance company would probably use up to 8 subgroups, and you could easily see how the 8 subgroups would be generated. If you take this and then bring it into actually a practical application, I still have the same 2 dimensions here. My horizontal dimension is disease, my vertical dimension is health. And I'm starting in the lower right-hand quadrant with people high morbidity and mortality, little self-help or hope. If you move horizontally, you're doing traditional biopsychosocial interventions. That's never going to get you in the upper left-hand quadrant, recovery and health. The only way you're going to get there is by also introducing wellness approaches, self-help, social support, changes in unhealthy lifestyle, peer support, all these various things that permit you to develop wellness so that you not only can deal with disease, but you can deal with the other side of the continuum here, wellness, which is a different concept. And you need both. The argument in this graphic is you need both in order to move to the upper left-hand quadrant. Some of the pervasive national concerns in behavioral health currently, so if I were doing a little survey of you people on the phone today and I asked what is the most worrisome thing to you, most people, if they're honest, would say they're very worried about integrated care services. And we may have some questions about that, and I'll talk a little bit more in a minute about developing better linkages with social services, and I'll come back and say why that's true. Incarceration has become a huge problem for mental health and substance use, and then finally linkage with public health. I see these as the four basic, they're partly political problems, but they're also organizational problems for behavioral health going forward here. Now, say a few words about each one of them. So first, on integrated care services, what you see in this overhead is a two-dimensional array. The factors on the left are dimensions that could be looked at in terms of integration. So how does a person access care? How is care delivery offered in an integrated system? How is payment done? And how are outcomes? What outcomes can you expect to achieve? And then you see across the top models 1, 2, and 3. Model 1 is traditional treat refer. Model 2 is bidirectional integration, which is what we're doing now. And model 3 is a model looking into the future that we would call full integration. In full integration, you have fully integrated treatment teams and fully integrated money. What this matrix allows you to do is look at any organization and classify it for the four dimensions: access, care delivery, payment, and outcomes, into one of the three models. I do have a paper I've done in this area. If you're interested, and you'll let Christy know, I'll be very glad to provide that paper to you, and it will go into much more depth in this. Before I leave integrated care, I guess I would make a step back and make a little broader comment. On integrated care, we've been developing the policy of integrated care for at least 25 years, and I've written about that in a number of papers as well, for anybody who's interested. However, the practice of integrated care is literally just a few years old. And why is that? Because most people in behavioral health are afraid of integrated care. And if you get right down to it and you do a work group with them or a workshop and you say, what are your basic fears? The first fear that will come out is, I'm afraid I'm not going to have a job and my organization is going to disappear. So what we're going to need to do is address those fears. On the human resource crisis, clearly there should be no worry that anybody will not have a job. There's much more work than possibly can be done by the current behavioral health workforce. I would say you may not be working in the same organization and there may be a new label on the door, but that doesn't mean you're not going to have a job. So I think we have to deal with this problem of people's fear of integration before we're going to make strong strides to actually move it forward in a very big way. Social services, why are social services so important? What this shows is a little heat map of the United States, and it shows in deep blue those states that are spending much more on social services relative to medical spending, and the lighter blues down to the grays are showing the states that spend less on social services relative to medical spending. Why is this important? It's important because we've learned both with using countries as a unit of analysis and states as a unit of analysis, those entities that spend more on social services relative to what they're spending on medical care will get much better outcomes from their medical care interventions. And there's a beginning to develop a literature on this that is going to, I think, have a very significant impact. So, if I relate back to what I just said about integrated care, part of the future problem of integrated care is how are we going to integrate social services into that integrated care model, and what form will that take? There actually are some demonstration grants that CMS is currently doing through the Innovation Center looking at various approaches to that very issue. The incarceration crisis, a lot of numbers on this graphic, but the important number is in the bottom, 920 or 910 per 100,000. Basically, that's one person per 100. So actually, tonight, one person per 100 in the United States is going to be incarcerated somewhere. That's the highest rate of any country in the world. And if we say, how many people are actually involved in the criminal justice system, although they're not incarcerated, they're on home detention, probation, parole, some of these other statuses that I mentioned, we're dealing with 4 out of 100, far beyond any other country in the world. And I think there's bipartisan support to the idea that the correctional system is not working and that we actually have to do something about it. And why do I raise this in the context of behavioral health? Because for city and county jails, and I believe I have another overhead here, tonight there are going to be 730,000 people in the city and county jails of the United States. 75% of those people are going to be people who have behavioral health conditions. You see the relative distribution there. About a quarter will have a mental illness. Maybe 15% would be those people we would call adults with a serious mental illness. Half are going to be people with a substance use condition. There's going to be huge overlap. You're going to have mixed into that people with intellectual and developmental disabilities, people with epilepsy, people with traumatic brain injury, et cetera, et cetera. So we've gone from a situation 20 years ago where I would never be talking about this because it didn't exist, to a situation now where these jails have in effect become the home for huge numbers of people with behavioral health conditions. And we are undertaking some initiatives both in the National Association of Counties and my organization working on that. I don't really have time today to go into depth on that. If you have interest in that, I'll be happy to talk individually with you. Another very important thing here to point out is that under the Affordable Care Act, the county public health director in effect becomes the person who has the expectation of organizing all health systems of care in a county. What I'm showing you here is the 1,943 county public health departments and where those county public health departments are located. If you don't know who your county public health director is, you should go and have lunch with that person, come to learn who they are, what their plans are, to move this agenda forward, et cetera, et cetera, et cetera. And as I said before, this is doubly important for behavioral health because we are going to become a public health discipline going forward. Now, a few other things. I want to talk a little bit about repeal and replacement of the ACA. So what I put in here, and I've done this for the ACA, Medicaid, and Medicare. So what are our concerns? So if I were putting myself in the role of behavioral health person, I'd say, what are our concerns here? Our concern here is that there be good health insurance coverage for people that has good benefits, that there be good access to care for everybody, and that we don't care as much about whether you call this Obamacare or whether you call this the ACA. We care that these factors are present: good health insurance coverage and good access to care. In the ACA, we are concerned about what's happening to the Medicaid expansion. And if you will recall, the bill that was introduced, the American Health Care Act, a few weeks ago, would have taken down the Medicaid expansion beginning in 2019 and would have taken nearly $900 billion out of Medicaid. We need to pay attention to that. Another thing it would have done is taken away the subsidies that are given to people in the marketplace and replaced it with an after-the-fact tax credit that would have been much smaller, that simply would not be useful to people who use the marketplace because they're simply too poor for a tax credit to be meaningful. So we want to understand, repeal, rename, and replace. And I would say one of the credits to the Protect Our Care Coalition, that the dial between January 3rd, when this process began, and 2 weeks ago when this bill went down, we were able to change the dialogue from just repeal to repeal and replace or repeal and repair. And that changed the whole configuration of what actually happened in the Congress. And so I think advocacy on this absolutely does work, and you absolutely must be doing advocacy. And if you want me to plug you into the Protect Our Care Coalition, I'll be very glad to do that. We want to avoid the trap about labels and say, oh my God, you know, we have to call this Obamacare, we have to call this ACA. We don't care as much about that as we care about what's actually going on. So what this little overhead shows is some of the things that would have happened in the American Health Care Act. It's less important now because that particular act is not going to happen. The bottom line, it was a very bad bill for all Americans, and it was a very bad bill for people with mental health and substance use conditions. Medicaid, so another effort that's underway on the Hill. It would have become part of that act had that act actually been implemented, but now may come in another form, is converting Medicaid from being an entitlement program to a block grant program. And the mechanism that was being talked about on the Hill at that time was a per person block grant. And this means for every person enrolled in Medicaid, there would have been a fixed amount of money. A critical issue in that environment becomes, what is your baseline? What year are you using as your baseline, and what factors are you putting into the baseline? And then how are you adjusting for inflation? Well, the American Health Care Act we just talked about a second ago would have adjusted the person-focused block grant on the general consumer price index, not the medical care price index. The general consumer price index in recent times has been between 2 and 3%. The medical care consumer price index is 5 to 6%. So immediately out of the chute, within the first year, you would start losing 3, then you'd lose 6, then you'd lose 9, then you'd lose 12%. So in 4 or 5 years, if you were in a constant system, you'd lost 15 to 20% of your purchasing power. So we do not favor conversion of Medicaid to a block grant, whether it be a per person in the population enrolled or per person in the general population. We think that there needs to be more discussion of this, but we think that the discussion should not be about the federal and state roles. That one of the tools being used to try to sell this is that we're going to give flexibility to the states. Well, yes, that may be true, but you're giving flexibility to the states by, a sleight of hand by taking money away on the other part and trying to move the burden of the Medicaid program from the federal government down to the states. So this is something that deserves watching. You need to watch when people come back from the Easter recess in a week or so, what is going to be the dialogue on the Hill regarding this issue. Then the third one is privatization of Medicare. Another interest of Secretary Price has been privatization of Medicare. A lot of bells and whistles here, but I think the two important points would be you would no longer have comparable benefits under Medicare from place to place and state to state the way you currently do, because all of the insurance would be provided by private companies. And the money you pay for Medicare, which now goes to the federal government, Part A in your pay stub, certain portion of your pay stub pays for Part A, the hospital portion of Medicare. And then when you retire, the ambulatory portion of Medicare and the doctor portion of Medicare is paid with premiums. That money would no longer go to the federal government. That money would go into 401k plans that would be managed on Wall Street. So those are the two principal changes. We think that it's not good to try to do this to elderly people who don't understand insurance as well to begin with. And it's a form, in my opinion, of trying to take advantage of people who are less sophisticated on some of these issues. You should also know that Medicare is a huge payer for behavioral health care. We probably have as many as 4 million people who are enrolled in behavioral health care services who are what we call dual eligibles. They're eligible both for Medicaid and Medicare payments. So this is another one to watch and see how it begins to play out as the congressional calendar plays out over the next several months. So I want to point out that I do commentaries on all of these things that I've been talking about. All of my commentaries are available at www.behavioral.net, and you can go out there and read about any of these things. And I usually do a commentary about once every 2 weeks. I'm I'm working on a commentary right now about some of the things that peers have brought to behavioral health care, including some of the concepts of recovery, et cetera, et cetera. So if you're interested, you can go out there and look at these things. So which is it going to be? Are you going to go down an interesting trail, or are you going to be bored here? And I myself want to go down an interesting trail, and I hope you do also. So with that, I'm going to stop. Here's my contact information, and I think we're going to have a little time to do a little Q&A here.
Yes, we will. Great. Thank you so much, Ron. That was an excellent presentation and very informative. That was a great summary of all of what's going on currently for policy implications. Traditionally, I like to give Peter the first chance to ask a question. Just a reminder, if you have a question, please go to the questions area of the GoToMeeting toolbar and enter your question there. If you have a comment, please try to maybe turn it into a question if you can. It's a little easier for our speaker to answer that way. So Peter, you want to ask your question?
Thanks, Christy. Ron, thank you very much. Very, very comprehensive and yet a lot of depth as well. So I appreciate that. I learned quite a bit. I want to take you back to the integration. And as I've been sort of watching the literature and hearing about things over the past several years, there's this constant sort of, interest in getting the primary care delivery systems to integrate behavioral health into these systems. What I have not seen is how do these primary care delivery systems think about that? Is this something that they can do? Is it reasonable for them in terms of resources and scope? Do they feel this is just being thrust on them, or are they excited and wanting to do that? So they have a lot on their hands as well. So how would you respond to sort of those questions?
Okay, so it's a kind of a couple level response. So I guess the first level, how are they going to get the capacity to do this? There actually is Section 2703 of the Affordable Care Act provides funding to create accountable care organizations that actually do integrated care. And there are a lot of bells and whistles on that. You can go and read what Section 2703 actually states and so on. But there is funding and resources, including for IT and for services development, so on, to allow you to actually develop one of these integrated care systems in an accountable care organization. An accountable care organization can either be a fully integrated operation where all of the services are under one single management structure, or it can be a coordinated operation where several organizations come together, create an umbrella, and then the umbrella operates the accountable care organization. So there are multiple models that are permitted, the funding that's available through CMS. There also is the Assistance Center that's jointly funded by SAMHSA and HRSA to help entities actually develop this capacity. And I believe that a number of grants are currently being funded at the local level to do this. I also believe that SAMHSA is getting ready to award, I believe it's 11 state grants to belong. There are results in the environment to make this happen. So side, why would these people ever want to do this? They would want to do this because 75% of all people with behavioral health get into the specialty system I was just telling you about. Those 75% of people are served only or primarily through primary care physicians. So someone will come in and say, I'm not feeling so well, and I've not had much energy, and I don't sleep very well, and let's say the conclusion is that that person is depressed. Well, that primary care physician is going to medication for depression, basically. 75% of people who are served for behavioral health conditions get their care from a primary care physician. Now, that being the case, a large number of that 75% are people who are what I'm going to call difficult to treat. So the person may come with depression, but they may have refractory depression where what the primary care physician knows or does by trial and error doesn't work. So a lot of primary care physicians have come to realize that it's of great benefit to actually work with behavioral health people who can help them in this area, because if you can help one of these more difficult refractory cases, you can actually control the cost of that case. So I think it's partly pragmatic, and it's partly because they love being loved and want to serve people well that they are more willing to do this. There also are various grant programs. One I would cite, I believe, in the state of Colorado, a physician named Larry Green received a fairly large grant to implement integrated care in, I believe he's got like 25 sites in Colorado currently, and he's coming at this. He himself is a primary care physician and well known. He's in the National Academy of Medicine and so on, who's giving credibility to this and is actually developing appropriate technical assistance for primary care practices to make this easier for them. So they're kind of these 3 or 4 levels you could cut into your question at, and I think the vectors in those 3 or 4 questions align in the same way, that we're going to continue to do and move toward integrated care. I don't think that train would change no matter who's president or what we do with the Affordable Care Act. And we need to help people make that transition as good as we can so we don't end up with a lot of casualties along the way.
Thanks, Ron.
Great, thank you so much. I have one housekeeping thing. Ron, would you mind if we posted your slides from today to the website with the recording as well?
No, that's fine.
Okay, great. I have a lot of people excited to have the slides. I have a question here from our audience. If you were asked to start up an integrated care system today, would you start with a well-functioning behavioral health agency and build upon it, or would you start with a well-functioning physical health agency and build upon that?
Well, I would want to do both. The reason I want to answer it that way is because we want to see both of these develop in the community. We think that's a very healthy approach to this. And so what I was just answering in Peter's question, I was answering it from one point of view. I was answering it from the point of view, if I were creating this system in primary care, here are some of the features we'd want to look at. I could make the same comments I just made about, building the system from the behavioral health side. And I think it's equally as important. So if we fast forward that 75% and we go forward in time and we factor in all the new people I told you about who are enrolling in the Affordable Care Act, and we go out about 10 years, I guess my 10-year prediction would be 10 years from now, assuming all of this moves forward, probably 90% of people are going to be seen in integrated systems that are built out of primary care. 90% of people with behavioral health conditions are going to be there. 10% are going to be on the other side in integrated care systems that are built out of behavioral health care. And it's an oversimplification, but more or less the most severe cases will be on the behavioral health side, and the less severe cases will be on the primary care side. We need both of those systems. So if I go to this very severe side of behavioral health care and say, well, these 10%, so I'm sure some of the people who are listening are saying, well, 10% isn't 25%. How has this changed? The numbers will be the same because of the growth in the number of people who will be cared for. So in effect, we'll be dealing with the same number of people in behavioral health now. It's just that we're going to be dealing with a more severe group overall. The primary care people will also be dealing with more people, but they'll pick up a lot of the less severe people who in a more traditional behavioral health system would have been served in behavioral health. So why is that so important on the behavioral health side? Because we know that for these very severe people, the people who are in population group 4 that I was talking about before, I know from my own research, those people die 25 years younger than other people. A woman dies at about 58, a man at 52 to 53. What are the factors in them dying early? So I've already told you one, of poverty. So tell me you were born in poverty, I'm going to take 5 years off your life. Tell me you didn't graduate from high school, another 4. Tell me you have refractory depression, another 5. Tell me you were treated in the public mental health system, 11. I've taken 25 years off your life just on those 4 variables. Those people have serious health problems in addition to behavioral health problems, and they need a strong behavioral health system that also has primary care in it. So I don't want to pick one or the other choices. I want us to move both sides forward as best as we can, because I think that's what we're going to need in the future here.
Great, and that segues me well to the next question. So I think a lot of people on the line are probably interested in what skills and training do you think that the behavioral health workforce of today and very shortly tomorrow will need to be able to help move the integrated care forward?
So that's another very good question, and part of the issue historically, there's not a lot of literature you can go to look at that question. Going forward, several things are beginning to develop. I'm going to cite one, and I believe there are a couple others, and I can get the citation for a couple others. So in just a few weeks, the American Psychiatric Association will be issuing a new book on integrated care. Well, one of the purposes of issuing that book is to begin talking to psychiatrists about the kinds of skills that psychiatrists and others are going to need to begin moving into integrated care delivery systems. So I think you're going to begin seeing that type of tool out there. You're going to see a lot more technical assistance about things like this. Companies like Health Management Associates are going to be doing webinars about these things and so on. Some of the nodes in that I think are very important. So an integrated care system, as I said, if we move to this Model 3 that I was talking about that we discuss in our paper, we say we need to have fully integrated treatment teams. And by that we mean that we have a treatment team that has a primary care physician, maybe a nurse, a primary care physician assistant, a behavioral health specialist, and a peer specialist from behavioral health. Well, in creating that, we're going to have to train people how to work in these teams in a way that they have never done before. And so there's a lot needed to develop that capacity. You're also going to have what I'm going to call a system integrator. In that, a system integrator will be a person who will pull together a case before that team ever works with the case. So there are going to be some new roles that are going to be created here that really haven't existed in the past. And there are going to be some new activities and roles that have existed. For example, with peers, we've had peer support specialists in behavioral health. We have not had peer support specialists in integrated care systems. And I don't see this as a problem. I see this as a huge opportunity to move that agenda. And we're just going to have to work out some of the training that people are going to need in order to be able to get there and do this. And as you know, entities like the American Psychiatric Association or Mental Health America and others take these things on, you're going to see more and more about that out there. And you're going to actually see, I think, more training actually done by the government in this area. I think, for example, the Center on Integrated Care Service that's funded by Samson HRSA also, in some of its technical assistance through webinars, talks to some of these training issues already. So that's a very, very good question, very important question.
Great. Thank you so much, Ron. We had so many great questions, but we really have 1 minute left, so I'm going to go ahead and cut off our questions at this point. Thank you so much for today's presentation, and we really appreciate you taking time out of your schedule to give such an informative talk, and I know that we really appreciate you joining us today. And Peter, you as well? We lose Peter.
Well, I had you on mute. Sorry about that.
Oh, sorry.
Indeed. Thank you very much, Ron.
Okay, take care. Glad to do it.
Great.
All right.
Great, thank you so much. And as I mentioned, our next event, webinar event, will be the challenges and opportunities facing the psychiatric mental health nursing workforce, to be held on May 11th at 1 p.m. Eastern Standard Time, featuring Dr. Kathy Delaney. Thank you so much. Have a great day.